Preterm birth is the leading cause of global child mortality today. And preterm babies are very, very likely to suffer from respiratory distress. We know in high income countries how to treat respiratory distress with either nasal oxygen or continuous positive airway pressure or CPAP. And the introduction of these technologies made a tremendous improvement in the survival for preterm babies in high income countries. Today, unfortunately, CPAP is not widely available in low-income countries. Our team has been working to develop CPAP technologies that are affordable, that are rugged, and that are effective. And we've been working to roll those technologies out countrywide in Malawi, a country in sub-Saharan Africa that has the highest rate of preterm birth in the world. Our team has been working very closely with the College of Medicine at the University of Malawi and the Ministry of Health in Malawi to see how we can change the availability of CPAP to help provide this therapy for preterm babies at every hospital in the country. Since 2013, we have been working to scale up Pumani, a low-cost, rugged CPAP machine, to every government hospital in the country. Together, what our team did was we partnered with the Ministry of Health to look at what were the rates of survival for babies before CPAP was available. How are they doing with the technologies that were available? And then we introduced CPAP into the hospitals, trained nurses to properly use CPAP, and we trained biomedical technicians to keep those CPAP machines going. And we monitored how well babies with respiratory illness did after CPAP was available. And what we found, very excitingly, was we found that there was a statistically significant improvement in survival for babies that had respiratory illness after CPAP became available. For babies that had respiratory distress syndrome, these are the tiniest babies that have some of the biggest challenges with breathing. We saw nearly a 10% improvement in survival after CPAP was available. And for me, the most exciting thing is we saw that improvement in survival could be sustained in routine care. As part of a nurse-led CPAP program that was introduced and sustained by the Ministry of Health, we saw that this improvement in survival could be sustained over time. We also saw a lot of the challenges of scaling CPAP in a low-income country, in fact, one of the poorest countries on the continent. What we found was that CPAP outcomes were worse when we had rotations in the nursing staff who were working in the ward, or when there were power outages in the ward. We also found that hypothermia was pervasive in these wards. Babies, unfortunately, all too often were too cold. When babies were sufficiently warm, when they had a normal temperature, their rates of survival were much higher. So we know that it is possible to scale CPAP nationwide and to sustain that in one of the poorest countries in the world. And that when you do that as part of routine care, you see a significant improvement in outcomes. But there's more work to be done. We know for CPAP to have its full potential, it needs to be introduced as part of a quality program that focuses on improving essential newborn care.